kicking us off is Kathleen from the University of Antwerp, and the talk title is Using On-Mobility Spectrometry for Early Mesothelioma Detection and Asbestos-Related Individuals and External Validation. Since 2022, Kathleen has been dedicated to her research on pleural mesothelioma and aggressive asbestos-related cancer. Her work focuses on developing non-invasive breath tests for early detection. To further advance biomarker development, she plans to utilize the test for follow-up with professionally asbestos-related individuals at risk.
Hello, my name is Kathleen Zwijsen. I am a PhD student at the Laboratory of Experimental Medicine and Pediatrics at the University of Antwerp, which is situated in Belgium. I've been doing my PhD for about a year and a half now, and I would like to share some results with you about our use of ion mobility spectrometry for early detection of mesothelioma in an asbestos-exposed population, where we have created a binary classification model, which we will now externally validate. So, pleural mesothelioma, the disease we're investigating, is a tumor of the mesothelial cells of the pleura of the lungs. It is strongly associated with asbestos exposure. Currently, there are no screening programs available for this disease, and due to a combination of its long average latency period of 30 up to 50 years, non-specific symptoms, and also invasive diagnosis techniques, it is characterized by a late-stage diagnosis. Therefore, we feel there is an unmet clinical need for non-invasive and early-stage biomarkers. Therefore, we have investigated volatile organic compounds, which you obviously all know, that we feel these volatiles, especially since mesothelioma is characterized by chronic inflammation, the production of reactive oxygen species, we really feel that VOX could be used as non-invasive biomarkers, which is exactly what this disease needs. Therefore, my promoters founded the Mesothelioma series, which is a series of studies to find a way to distinguish between asbestos-exposed individuals and mesothelioma patients, really. So in the first study, Mesothelioma 1, we had a proof of principle study where we included patients with mesothelioma, lung cancer, COPD, asthma, and also healthy persons with an asbestos exposure, and found that with only 11 volatile organic compounds, we could distinguish between asbestos-exposed individuals and mesothelioma patients. Afterwards followed a technical validation where we really optimized the use of our technique, a translation in vitro to correlate any VOX that were found in mesothelial cell lines and see if they correlated with what we found in our clinical research, an updating of the model last year by my colleague Ellen Janssens, where we reduced the amount of volatiles that distinguished between the groups of asbestos-exposed individuals and mesothelioma patients to only 4 volatiles. And currently we are performing the external validation of this updated model, which I will talk to you about in this presentation. So for an external validation, we need a study population. So we included individuals that had a professional exposure to asbestos of at least 30 years ago, because as I said, it has a long average latency period. So we wanted people who were exposed a long time ago, so at least 30 years ago, with a minimum of 15 fiber years. 5 years is really a sort of quantification of the amount of asbestos a person has inhaled. But this fiber years calculation is based upon the subjective retelling and recalling of the participant. So this is a sort of subjective measurement, but we tried to include people with quite a high asbestos exposure. So 15 fiber years is a very high exposure. They performed a breath test in 2021, 2022, apologies, and 2023. Additionally, we included mesothelioma patients from the University Hospital in Antwerp to be our positive controls. So for our methods further, we used MCC-IMS, so multi-capillary column ion mobility spectrometry, to create a classification model, as I said earlier, through lasso regression with Lee-Barnard cross-validation. So we created the model on another population, and now in our external validation, we will recruit new individuals to validate this model upon. But the original model was created with lateralization. And this is a model with 4 volatile organic compounds, and we will apply it to our new study population. We asked our participants not to eat, drink, or smoke 2 hours prior to their breath sample, to rinse their mouth with distilled water and wear gloves. And we performed alveolar air sampling through capnography, where we measured the CO2 plateau that characterizes the expiratory plateau, so that we only measure alveolar air. Afterwards, the sample will enter the multicapillary column, where, based upon its retention time, a first separation occurs. After ionization, there will be a further separation of the molecules based upon their molecular weight. So now for our results, we were able to include 7 mesothelioma patients and 121 asbestos-exposed individuals. There are significant differences in age, in sex, mean pack years, and age, though none of these volatiles were significantly correlated with any of the VOCs that were previously found in the classification model. So we applied the model onto this new study population, as I mentioned earlier. So this is a visualization of these results. Don't worry, I'll guide you through it. In green, you can find the asbestos-exposed individuals, in blue mesothelioma, and gray are the people who we missed during 1 or 2 measurements. So at the top, you can see our 7 mesothelioma patients, and at the bottom are asbestos-exposed individuals. In the first column, you can see the actual class of our participants at inclusion. So mesothelioma patients had received their formal diagnosis. They are patients, and none of the asbestos-exposed individuals we included had any sign of disease, or we had no worries that they were developing meso. After the first measurement in 2022, we let the model loose onto the breath print of these new participants, and we asked it to predict into which category these participants would fall. So as you can see, all our pleural mesothelioma patients were correctly classified by the model. And at the bottom, you can see that actually a lot of our asbestos-exposed individuals were actually considered to be having mesothelioma by the model. Why this is? Due to a confounding factor, maybe there's still some other model updating necessary. This could all be the case, but we have a quite high level of false positive results. Same thing actually for prediction 2. So all pleural mesothelioma patients were again classified correctly to be having mesothelioma, and we had some false positive results. Now in the fourth column, I will show you our double positives. So this means people who were positive twice in a row in both breath tests. Now, why do we repeat this breath test? We want to adhere to the test-retest principle, where we repeat our breath test to reduce false positive results and to ensure really reproducibility of the breath test. And also, because it is a disease with a long latency period, if we want to pick up anyone developing the disease, we will have to measure serially and maybe over a couple of years, which we are doing now. So these are the model characteristics after the second breath test measurements. So as you can see, we have quite a high sensitivity and negative predictive value, low specificity and accuracy. But due to its high sensitivity and negative predictive value, we feel that the breath test has use. We can use it to rule out disease in an at-risk population, and also we focused on detecting our true positives to not have any, to not miss anyone who's actually ill, and to really focus on being able to pick out people who are having or developing the disease. So in the future, we wish to repeat the breath test 2 more times. So I've gone to companies where people had the asbestos exposure professionally, and I will do that twice more, so once in 2024 and once in 2025. And from this year on, we will start to correlate these findings with CT imaging, and we will perform a low-dose CT scan. And we hope this correlation of our breath test results to these CT images will provide us some more insight into whether or not what we are actually measuring, what is the clinical state of these patients, do they have a very high asbestos exposure? Is that something we're measuring? And is that the reason why we're having such false positive results? We really hope that this will give us some more insight into the outcome of the first 2 breath tests. And we will start with our double positive participants, because we feel that these people have the highest risk of being potentially developing mesothelioma. Additionally, we will perform GCMS analysis, where we want to identify the specific volatiles in our validated model, or the model that we are validating better. Because a characteristic of the use of MCCIMS, of course, is that it is only a semi-quantitative technique. We know some of the chemical properties of the compounds, but we cannot really be sure of their true identification. Therefore, GCMS would be a lot more suitable, and as you probably all know, also more or less the golden standard of VOC research. So to conclude, we are externally validating a previously updated prediction model to distinguish asbestos-exposed individuals from pleural mesothelioma patients. We have a model that has a high sensitivity and negative predictive value, which we focused on because we want to minimize our false negative results, even though this may lead to a quite high result of false positive results. And we hope that the use of CT scans will allow us to identify the development of mesothelioma in some of our participants. Obviously, not all of them will be developing mesothelioma, or to identify what are some confounding factors that currently we are not taking into account and might really be useful to update our model with. Lastly, always many people to thank in research. So everyone at the University of Antwerp, in other universities, and also university hospitals in Belgium. Thank you very much. And thank you for your attention and for reviewing this presentation.
Thank you so much for the talk. Thank you so much. Really appreciate it. So we've got time for a few questions. So the first relates to the use of mobility spectrometry. Are you able to identify the VOCs in the panel, or are you just calling it VOC 1 and 2 for IP?
Yeah, for now we are so it's a semi-quantitative method, so we do know the retention time and some other chemical characteristics of the compound, but we cannot be entirely sure as you can be with GCMS. So therefore we are planning on doing GCMS analysis as well to really pick out which compounds we are measuring. But for the moment, we know that it's carbohydrates, so 3 carbohydrates that we have, and then the 4th one is an aldehyde. So we have an idea of what the compound could be, but to be absolutely sure, we should do GCMS analysis.
Okay, that's great. And that leads on to the second question. So you have a sense of what they are, so you can have a bit of a sense of the underpinning biology. You mentioned it likely relates to inflammation, oxidative stress. Given other conditions are likely to lead to the production of those types of VOCs, I wonder if you could comment about the performance of the test, if you translated it into an intention to diagnose type population where the disease is much rarer.
So actually we have compared, we have applied this panel also on other diseases to see if we can also distinguish other pulmonary diseases such as COPD, asthma, and now it was actually able to still have a nice distinction. So we feel that any pulmonary disease we can sort of pick out. The problem is that it's always with a high sensitivity and still a quite low specificity. So that will be our main focus point in the future to figure that out. Got
it. Next question here is, what treatments are available for early stage disease?
Well, currently the disease is not curable. Well, there are some treatments, none are really in clinic considered curative. So you have surgery. If it's a really early stage, you can have a pleurectomy where they remove certain parts of the pleura. And then later on, if it's an unresectable case, you would have chemotherapy, and also immunotherapy has been approved since 2020 by the FDA. So that is also being used in Belgium, I know, but I don't know in the UK. I know in the Netherlands it's not being used, but those are really the only options those people have. And then still it's in the palliative setting mostly.
Got it, thank you. Next question loops back onto the GCMS work that you're planning. So will you use the same GC column so you're able to correlate the retention times? Is that the plan?
Really, I haven't considered that, but that would maybe really be a good idea to see that we have comparable results. We are planning to do this in 2025. We will obtain the GCMS results, but we're really looking into how we will incorporate both our MCC-IMS data with this GCMS data. So it would be interesting to use similar columns to have a comparable result indeed.
Brilliant. Next question relates to the use of IMS. Given your experience, what are the challenges or nuances one should be aware of using IMS for other applications such as diabetes or metabolic disorders? So any kind of tips or tricks that you could give the audience? Well,
what we do right now is we also take a background sample, just to make sure that whatever, I think that's very common in breathomics, but just to be sure that whatever we are measuring is actually in the patient and not in any external factor. But this makes it so that we may miss some very low abundant volatiles in our samples. And it's also a common pitfall of MCC-IMS that it is not or one of the most sensitive techniques that there is. So I think to be aware that maybe if you're really looking into pathway analysis, you will miss some of the most low abundant FOX. So therefore, I would recommend if you're doing pathway analysis, go for GCMS. If you're just looking in a clinical application, MCC-IMS is a very handy and also an online technique that you can use. But sometimes it can lack a bit of sensitivity.
Since smoking can affect breath VOC patterns, how are you considering the influence of cigarette smoke or past smoking in your analysis? And how might these factors impact how well the model performs?
So for the moment, we had no significant differences between our populations on their smoking habits. And also, I have not included that, but none of the VOCs of the 4 VOCs that are in the model were correlated with any of the clinical characteristics that I've shown you. So for now, we have not done anything to really correct for the smoking behavior of our participants, but that is something we are actually planning on doing because cigarette smoke really can impact the fog patterns of people, which you'll probably know. So we want to include that as a parameter in our model in the future.
Brilliant. As well as the future planned work, has some of this work been published, or is there a paper been written up at the moment?
Yeah, last month I published the first results. So the first visit to the companies in year 1. I published it in the Journal of Breath Research. So if anyone wants to have a look, feel free. I can send you the PDF if anyone wants it.
That'd be great. We're very happy to share that with the whole audience. So thank you so much for the time, Kathleen, today coming to.
Thank you so much for having me. It's really been nice.
Thank you so much.